studies. I'm not going to go into the specifics of the treatment paradigms, but really kind of looking at what does exercise look like for our patients with FSHD. And when we think about it for our clinic population, really I think two key questions come to mind, and that is it safe? Can we tell our patients that they can engage in an exercise regimen and do it safely? And is it effective? And when we start thinking about whether or not the exercise regimen is effective, we start thinking about what types of exercise are we going to inform them to do. Is that going to involve aerobic training and really training the cardiovascular system? Is it going to involve strength training and really trying to improve individual muscle strength? Should it be a combination of the two of these or some other different combination? How long should they do it? How often should they do it? And so these are just some of the questions that we'll try and address during this talk today. So first we'll start with, is exercise in FSHD safe? So this is a study that was published in 2013 looking at the response of CK levels to high-intensity aerobic exercise in adults who had muscular dystrophy. And so in this study, they actually enrolled 14 participants. 5 of them had FSHD, and they also included individuals who had limb-girdle muscular dystrophy as well as Becker muscular dystrophy. And the exercise paradigm that they used was sequential cycling tests over the course of 5 different weeks. And so they were evaluated at baseline to establish their VO2 max, and then they came back once a week and did exercise assessments at 65, 75, 85, and 95% of that VO2 max. And the investigators looked at CK levels measured right before they did the exercise, immediately following the exercise, and then again at 24 hours post-exercise. And so these are the results from that study. This is the FSHD participants here. I don't think you can see the arrow here. This doesn't really work, does it? Yeah, bummer. So the bottom line is the individuals who are the healthy controls, and just above that are the participants with FSHD. And so hopefully what you can appreciate is the individuals who had FSHD, their CK levels increased after exercise, but then within 24 hours, those CK levels returned essentially to baseline. If you look just below that at the healthy controls, their CK levels went up after exercise, and then at the 24-hour mark actually remained elevated. And the similar thing was seen in individuals who had Becker muscular dystrophy. So if you look at the second line from the top, their CK levels also remained elevated. And then if you look at the dashed line at the very top, the individuals who had limb-girdle, their CK levels fell following exercise. So this study is really just showing that all of the individuals were able to complete the exercise regimen, and the CK levels returned to baseline or near baseline levels in individuals who have FSHD, suggesting that at least a short duration, high intensity exercise is safe in folks who have FSHD. So then we start thinking about, well, is it effective, and what types of exercise should we be doing, and what is the duration and frequency that we should be advising our patients on. So just kind of some historical context on where these exercise studies came from. Between the 1960s and 1990s, there were several exercise studies that were investigated in individuals who have muscular dystrophy, but those studies collectively only enrolled about 13 individuals who had FSHD. And these studies mostly focused on strength-based regimens. And so the conclusion from these studies was that strength training maybe had some positive effect and didn't necessarily increase susceptibility to muscle damage, but these studies were limited, they were small design, and they weren't specifically designed to evaluate outcomes in individuals with FSHD. So that's what I'm going to go over with you today, is looking at some of the more recent studies that have been conducted and looking at these different exercise paradigms, both from a strength training perspective and then also from an aerobic exercise perspective. So we'll start with one of the strength training exercise studies. And so this was published back in 2004. This study was published following a recent clinical trial in which albuterol had been looked at in FSHD and looked at the effects of lean muscle mass. And albuterol is known to have anabolic effects on the muscle, and so they wanted to see if this could improve muscle volume. And so in the clinical trial, they saw that muscle strength did not improve, but overall lean muscle volume and grip strength did improve. And so this team followed up on that outcomes from the clinical trial and wanted to see, could there be a synergistic effect between albuterol and strength training in FSHD? So they enrolled 65 participants who had FSHD ranging anywhere from 18 to 65 years of age. They enrolled them into 4 different treatment groups. I'm not going to go through all of this, but the first part of the study was allocating people to either a training group or a non-training group, and they specifically were focusing on training at the elbow flexors and training at the ankle dorsiflexors. And then in part 2 of the study, individuals in each of those different groups were allocated to either a placebo group or an albuterol control group. And so they used a combination of both resistance training as well as isometric and dynamic exercises in this study. And so these are some of the results from this study. Their primary outcome measure was looking at maximum voluntary isometric contraction, or MVIC. And some of the results from the individual muscles they tested are in this panel here on the left. So individuals who were in the placebo-treated group have the light gray bars, and those who were in the albuterol-treated group have the dark black bars. And you can see there was a mild improvement or modest improvement in strength of these muscles that were trained in the albuterol-treated group, but when they looked at the overall increase in MVIC at the elbow flexors at 52 weeks, they actually didn't meet their primary outcome measure. But they did see improvement in the dynamic strength, which they measured as a 1 rep maximum, so how much could the individual lift, and they did see that there was improvement in the dynamic assessment. Unfortunately, in all of the groups, the ankle dorsiflexion strength continued to decline despite the treatment group. But they also looked at muscle volume using a CT-based method. That's the second panel that's shown here. So muscle volume are the 2 bars on the left side of the figure, and muscle mass is the volume are shown on the right side of the figure. And the individuals who were in the albuterol-treated group have the dashed bars, or the dotted light gray bars there, and there's less loss of muscle volume and maybe an increase in muscle mass in the albuterol-treated group. So it suggests that maybe there's a limited but positive effect of strength training, particularly on dynamic strength in individuals with FSHD. The same group also published a follow-up study looking specifically at the effects of training in albuterol on pain and fatigue, which we all know is a very common problem in FSHD. So this is just another outcome that they assessed, and really they did not see any changes in pain, fatigue, or functional status or psychological distress in any of the treatment groups. So that was really the only strength-based exercise regimen of the more recent decades, and showed that maybe there is a limited but increase in strength that they observed in their study. So now we'll switch and move on to the aerobic exercise and looking at some of these different exercise regimens that are out there. So this study was published in 2005. They evaluated 8 patients with FSHD and included 7 healthy controls ranging anywhere from 18 to 60 years of age. The training regimen for this study was conducted over 12 weeks. They looked at the participants did 35 minutes of exercise that was controlled for their VO2 max, so they were in the low to moderate intensity of 65% of VO2 max, and participants slowly increased the number of times that they exercised per week up to 5 times per week throughout the course of the study. And so they looked at a number of different outcome measures. They looked at oxygen uptake with the VO2 max. They looked at maximal workload that the participants could generate, and they also measured the heart rate during these studies. They also wanted to see, again, going back to that safety question, is exercise safe in FSHD? And so they also performed needle biopsies before and after training to look at changes on the muscle biopsy. They followed the CK levels throughout the duration of the study and then looked at a number of different patient-reported outcomes, including walking function, muscle strength, endurance, and their activity levels and perceived level of fatigue. So these are the results, some of the results from this study. So in the FSHD participants, those who underwent the 12-week, or following the 12-week exercise program, they showed an increase in the VO2 max, which is the panel on the left, and the VO2 max also increased in the healthy subjects, as you would expect. In the middle panel is showing the maximal workload that the subjects were able to generate, and so this also increased following the 12-week exercise regimen in both the FSHD participants as well as the healthy subject. And then the panel on the right is looking at some of the patient-reported outcome measures, and so even though they reported no change in their walking abilities, it showed a number of improvements in other domains, including strength, endurance, their overall level of activity, and then there was a notable reduction in their perceived level of fatigue. So those were encouraging results. This is another study that was published in 2014. This was a slightly larger study looking at using a multi-center assessor-blind randomized controlled trial where they enrolled 57 participants in the adult range. They were stratified into 3 different treatment groups: an aerobic exercise group, a cognitive behavioral therapy group, and then a usual care group. And this study was specifically focused on individuals who had reported severe chronic fatigue. And so that was this specific study population, and they wanted to see, does exercise or CBT have any effect on the level of fatigue that these individuals are experiencing. And so they were, for the exercise treatment group, they completed 30 minutes of cycling a week for 3 times during the week. This was done for 16 weeks in a semi-supervised fashion, and then the participants were allowed to continue for an additional 12 weeks using a more unsupervised follow-up, an unsupervised regimen. The individuals who underwent CBT worked with a counselor and attended a minimum of 3 sessions, and each of those sessions was focused on one or multiple areas that were identified by that individual as areas that were contributing to their fatigue. And so they used some standardized assessments to identify these fatigue perpetuating factors. And then overall outcomes for the study were, again, looking at fatigue severity, which was their primary outcome for this particular study, but they also looked at the isometric contraction at the quadriceps, VO2 max. They looked at 6-minute walk test speed, and then again a number of the patient-reported outcome measures. And so what they found was that fatigue improved in both treatment groups, and this was maintained through the follow-up. And sorry, for those who were in the usual care group at the end of the first 16 weeks, they were then allocated to either the exercise treatment group or the CBT group. And so that was part of the unsupervised follow-up when they were reallocated to a treatment arm. So they also saw improvements in sleep, physical activity, and social participation, particularly for those who underwent the cognitive behavioral therapy. And in this study, they did not see any improvements or any changes in the VO2 max, the MVIC at the quadriceps, or the distance covered in the 6-minute walk test. And then one final study in this kind of low to moderate intensity regimen that was published in 2015. This study was, again, another randomized double-blind controlled study that enrolled 41 participants, 41 adults, and they were randomized to either a non-intervention group or a cycloergometer group. In this particular study, the investigators were interested in looking at protein supplementation at the completion of exercise to see how that affected the outcomes. And so in the intervention groups where they were doing the cycloergometer, there was a supplemented group and a placebo group as well. So all of the participants in the treatment group did 30 minutes of exercise 3 times a week for 12 weeks, and they again looked at many of the same outcome measures, VO2 max, workload, 6-minute walk speed, and then they also checked some of those kind of safety factors to make sure there wasn't any damage that was occurring, so they evaluated things like lactate, CK, and heart rate. And so these are the results, the main results from this study. On the top portion of the figure is showing the VO2 max. In the middle section there, it's showing the maximal workload, and then the bottom part of the figure is showing the walking speed. Those who were in the aerobic exercise group and received the protein supplementation are on the left side of the figure. In the middle there is the placebo group, and then on the right side of the figure is the control group. So in the training groups, there was an increase in the VO2 max and the workload, as well as the walk speed, but they did not see any additional benefits with protein supplementation beyond excuse me, beyond the training group. Can you get my water right there? Sorry. It's just on the floor there. Sorry about that. Okay, sorry about that. And then when they also looked at some of the patient-reported outcome measures, they saw that there were, again, improvements in some of the other domains as well. And then when you get back to the safety question, the lactate, CK, and heart rate levels were stable across all of the different groups. So when we kind of summarize what we saw in these low to moderate intensity exercise studies, the kind of general conclusion, even though they were looking at different elements, is that they saw a modest increase in the cardiovascular fitness, right? So the increases in the VO2 max, the overall workload, and even some in the 6-minute walk speed. And they notably didn't see any evidence of muscle damage on some of those safety labs that they looked at. And then I think also important to note is that they did see improvements in the other domains that the patients reported in some of their PROs. So lots of good things to kind of summarize from those studies. And then finally, we'll look at some of these high-intensity exercise regimens. So this study was published in 2017 and looked at 12 patients, 12 adults. They were randomized to 2 different groups. There was a usual care group, or a high-intensity interval training group, or a HIIT group, as many of us know it by. And so they were followed for 8 weeks, followed by 8 weeks of an unsupervised HIIT training. And at the end of that first 8 weeks, those who were in the usual care were allowed to do the unsupervised HIIT training. And so the intervention that they use is a little bit different than some of the others that we've discussed. And so the participants had an 8-minute warm-up period, followed by 2 cycles of 5-minute intervals. And each of those 5-minute intervals was broken up into 1-minute blocks. And so that's the diagram that's on the right. So for the first 30 seconds of that 1-minute interval, they were allowed to pedal easy. And then for 20 seconds, they pedaled hard. And then the last 10 seconds of that minute, they pedaled all out for whatever that meant for that particular individual. So they did that 5 times, and then they had a little break in between, and then they repeated that 5 times. And so that entire session took 21 minutes, and they did that 3 times a week for 8 weeks. Again, looking at some of the same outcome measures, VO2 max, workload, 6-minute walk test. They also included in this study the time to complete 5 sit-to-stand repetitions, and then also looked at different methods of muscle strength, some patient-reported outcome measures, and then also, again, looking at CK levels. And so these are some of the results from this study. The diagram on the right, those in green are the individuals with FSHD who were allocated to the supervised HIIT regimen, and the top part of that figure is showing that there's an increase in the VO2 max in these individuals. The red bars are the healthy controls, again showing an increase in the VO2 max. And then for the individuals who were in the originally allocated to the usual care group. When they were reallocated to or allowed to complete the unsupervised HIIT regimen, in the blue bars you can also see that even in an unsupervised format that there was an increase in the VO2 max in these individuals. And so their individual performances are shown in the lines below the bar graphs, looking at the VO2 max for those individuals. So when they underwent a supervised HIIT program, we saw improvements in fitness, so the VO2 max. They also saw improvements in the workload, and these improvements were maintained even through that unsupervised period. They didn't see any real changes in the time to complete 5 sit-to-stand repetitions, the distance walked in 6 minutes, or any of the other muscle strength measures. But again, in some of the patient-reported outcomes, they did show either improvement or unchanged in a number of different categories, but there was no worsening of perceived disease status. And then again, the CK levels remain stable in this regimen. So that was the only one looking at using a high-intensity model, and they saw modest improvements in cardiovascular fitness again, and then CK levels again remain stable, suggesting that it's safe to do exercise in FSHD. So most of those studies were relatively short in duration, 12 weeks, 16 weeks, maybe up to 24 weeks with an extension. And so this last one that I'm going to cover with you used a combination approach and followed these participants for 6 months using a home-based exercise program. And so they enrolled 19 individuals who were all adults, and they were allocated to either a training group or a control group, so a usual care group. And these individuals completed 35 minutes of cycling 3 times a week for 24 weeks, and they again looked at a number of these same outcome measures. For this particular, for exercise regimens, they did 2 sessions that were at a moderate intensity, so that's 60 to 65% of VO2 max. And then the third session was interval training, so similar to that HIIT method. So they used a combination method of exercise training in these individuals. So these are some of the outcomes from this study. On the left panel is again showing the VO2 max. In the middle panel is showing the change in the maximal aerobic power, or the MAP as they've abbreviated. And then on the right panel is showing the change in the 6-minute walk test. And so there were increases in all of these, as well as the quadriceps muscle contraction, or the MVC, that they also evaluated. Again, consistent with some of the other studies, they showed improvements in fatigue, but some of the other domains that they evaluated didn't show any improvements. They also completed muscle biopsies as a part of this study and showed that there was an increase in the fiber cross-sectional area on these muscle biopsies, and lactate CK levels also remained stable throughout the duration of the study. Just in the interest of time, there were a couple of other studies that have been published looking at upper extremity strength, single arm training, and different regimens, but in the interest of time, I'm not going to cover those. But I did want to just highlight this study that was just recently published this year. This is a retrospective review trying to look at the level of physical activity that individuals participate in throughout the duration of their lifetime, and trying to get a sense of how that correlates to clinical presentation and FSHD severity. And so the investigators defined physical activity of at least twice a week, participating in activities for more than 30 minutes, and then those activities they were doing for more than 3 months. And so they had a way to try and quantify this retrospective assessment of physical activity, and their conclusion was that increased physical activity during youth was associated with lower FSHD clinical score. So again, just highlighting that activity is a good thing in FSHD. So it's a lot of studies, kind of summarizing a lot of the results of what we have seen in exercise in FSHD. These are just a couple of quotes from the current evidence-based guidelines for FSHD as it relates to aerobic exercise, and the conclusion in what's recommended in the guidelines is that aerobic exercise appears to be safe in FSHD and may potentially be beneficial. And clinicians might encourage patients to engage in either a low-intensity aerobic exercise regimen and or a low to medium weights or resistance exercise regimen, but this should be tailored to each individual and really should be prescribed under the guidance of an experienced physical therapist who's familiar with working with individuals with FSHD. So just to kind of summarize everything, kind of going back to our original questions, is exercise safe in FSHD? I think after reviewing the literature and the studies that have been published, it does appear that individuals with FSHD can safely participate in exercise without an increased risk of muscle damage. And it does appear that it is effective in using a number of different regimens, that aerobic training can improve cardiovascular fitness, and strength training may improve some strength overall. And importantly, it can improve other areas of life that aren't quantitatively measured by strength or cardiovascular fitness, like fatigue and pain and some of the other quality measures that the patients reported. And that increased physical activity early on in life may have potential long-term benefits, as shown by the most recent retrospective study. So these are some of the references, and with that, I will take any questions.
For Natalie? All right, I have a question for Natalie. We're talking about a situation where I think clinical trials are going to be starting. You've reviewed exhaustively different approaches to exercise that people take. What's your feeling about advice we should give the patients or our sponsors as they're coming forward with their clinical trials and the role of exercise in their studies?
Oh, that's a really good question to take into consideration. So I think if patients are already participating in exercise and then are wanting to enroll in a clinical trial, we should be aware of that and advise them that that level of activity should probably be maintained throughout the duration of the clinical trial. Changes in exercise could potentially change the outcomes. So if they're already engaging in an exercise regimen, that probably should be maintained throughout the duration of the clinical trial. And then if they are interested in starting an exercise regimen, probably should run that by your physician first and maybe try and work with a physical therapist. I like to think of my physical therapists as personal trainers for my patients. That's how I like to get them involved in it, but just to make sure they're doing it safely so that it won't cause any adverse outcomes.
Okay, and then after reviewing the literature, because you really did, there's quite a few studies that have been performed in FSHD in your mind. Is there a study that hasn't been done that you think would be important for us to understand exercise better in this population?
Well, the kids, obviously. I think, and my background is in pediatric neurology, for those of you who don't know me, so I'm always thinking about the kids, and all of these studies that were done were conducted in adults, except for the last one that I highlighted, which is a retrospective, trying to get at levels of physical activity and how that correlates with disease severity. So I think it would be important to understand how that affects children with FSHD and what kind of advice we can give to those patients and families.
Okay, thank you very much. Okay, and so our final speaker is Enrico Bugiardini, who's going to be taking us through the emerging therapies for FSHD and the clinical trials.
Okay, thank you very much, Jeff, for the introduction. For me, it's an honor to be here and speak about clinical trials in FSHD. It's a very exciting moment for FSHD research, for clinicians, for patients, because we have many clinical trials, and we can start thinking or dreaming about a potential treatment in the near future. So in this talk, I'll try to give an overview of the current trials and therapeutic approaches. So these are my disclosure. And in terms of clinical features, I can skip this slide. I just want to highlight that there are probably 900,000 people with FSHD worldwide. So we are not speaking about a very rare condition. So they consider it rare, but there are a lot of people around the globe. And probably this is an underestimation because a lot of people are not properly diagnosed. If we skip the genetic, because Rabi did an amazing introduction on that, I think we have to focus on these slides to understand now the trial landscape. So we have DUX4, that is, we believe, the main cause of muscle toxicity. So as you can see, DUX4 can trigger a cascade of events affecting multiple pathways. So we have oxidative stress, we have an effect on cell growth, on immune response, on apoptosis, muscle atrophy, myogenesis. So you can, if you wish, target a downstream pathway, and there are trials on oxidative stress, for example, but it makes sense and is a sensible approach to try to target DUX4 upstream, to reduce DUX4 expression, and so to block the cascade. So this is the famous slide from the FSHD Society. I took this picture in February 2024, so it's very updated. They classify the trials based on these three categories that are the one that I use for this talk. So there are small molecules that are being designed, have been discovered for blocking or reducing actually the expression of DUX4. We have a big group of biologics to block DUX4 that now is the biggest group and is rapidly expanding with many clinical trials that are entering in phase 1, 2. And then there are other therapeutic mechanisms. So if we start from the small molecule to block DUX4, I mean, the approach that has been used was the one to screen massive libraries. So you take like 1,600 different compounds and you test them on FSHD1 myoblasts, and you try to see if you can reduce DUX4 expression. I mean, here in the picture, you don't see DUX4, you see other transcripts that are kind of surrogate markers of DUX4, because as Rabi said at the beginning, it's very challenging to measure DUX4, so we do use this surrogate marker that they give us an idea if there is an effect on DUX4 expression. So from this broad screening, from this paper in 2017, there were two big groups of compounds that were found. One, they are called the BET inhibitors, and the other one are the beta-2 adrenergic receptor agonists. So the BET inhibitors is interesting because they reduce the recruitment of transcription regulators to the D4, Z4 locus, and so they reduce the expression of DUX4. The main issue with the BET inhibitors that, in general, the ones that are called the pan-BET inhibitors, they can have a severe toxicity, and they are usually limited to oncology trials or indications. I did see that more recently in October, November 2023 has been published a paper on a specific BET inhibitors that is called APA-beta-alone that is more selective. It has been used for cardiovascular diseases, for pulmonary hypertension, so it can potentially be given chronically, so there is a better safety profile. So potentially, at least in the paper, they say it could be considered as a small molecule for FSHD treatment. But there is no trial available yet. The other group is the beta agonist, and that is interesting because, I mean, we discussed before the beta agonist, but as you could see, 20 years ago, there have been at least 4 trials on beta agonists. And that was mainly for the anabolic effect. At that time, we didn't know about DUX4. And there was an initial study that was very promising in 1998. They showed, it was a pilot study, an increase in muscle mass. Then they tried to do a bigger study on 90 people. And so there is not the point, I don't think it works. But the second one is on 90 people. It was a randomized study. But that one, the primary outcome was not achieved, so it didn't work. Then they thought to try to make more efficient, let's say, the use of albuterol, combining albuterol with strength training. But also in this case, the primary outcome was not achieved. And there was a question whether there can be a desensitization of the receptors. So they tried to give periodic administration as well. But also in that case, the primary outcome was not achieved. It's interesting to see that the beta agonists can suppress also DUX4. And it's true that the primary outcome was not achieved. There were some kind of positive effect on some muscles. And I also wonder, I mean, if you check here, the outcome measure that they used 20 years ago are not the one that we're using now for our trials. There is no reachable workspace, there is no fancy MRI. So I guess if we would repeat some of these studies, probably with a more potent beta agonist, I wonder if you could detect a better effect, considering also the DUX4 effect of the beta agonist. So from the beta agonist, then we get to the losmapimod, that is the current trial, and they get there mainly testing all the pathway of the beta agonist, and downstream the pathway there was the MAPK, so they block MAPK, that is a kinase with a very broad effect on cellular responses, including inflammatory cytokines, and they showed that stopping MAPK can actually reduce the expression of DUX4. So can potentially be a treatment for FSHD. The losmapimod, that is the drug currently tested, they took it, they tested in FSHD1 myocytes, and as the previous slides, they showed that DUX4, that is the black column, and other transcripts, they were downregulated, so there was an effect of losmapimod. The positive thing is that it's a drug that as well has been used for many other clinical trials, tested in 3,000 people, so there is a kind of safety profile. It can be taken orally. So the next step was to test it in a phase 2 trial. And this is a slide from the phase 2 trial. These are all data publicly available. And they tested losmapimod for 48 weeks in a placebo-controlled study. I think it's always important to remember that the primary endpoint was not met. There was the reduction of DUX4 at the muscle biopsy. There is a lot of discussion about why. I don't want to enter in the detail, but I guess one of the points was that it's very difficult to measure DUX4. You do need a biopsy. You may not actually have an appropriate assessment of DUX4 expression, and that was the reason why it was probably not. They didn't detect these changes in DUX4 expression, but they had some positive result in the secondary outcome measure. You can see on the left the MRI. There's a muscle fat infiltration, and those are the intermediate muscles, so there is some, let's say, mid-involvement of the muscle, so not too severe, not too healthy, and a placebo progressed in terms of fat infiltration. The losmapimod actually was more stable. Then they checked the reachable workspace. That is one of the main outcome measures in FSHD now. And as you can see on the top part, the people on placebo, they had a worsening. Not much, it's like 2%, 3%, 5%, but the people on losmapimod were stable or had 1% improvement. And then they showed also some benefits in the dynamometer, but not in all muscles, and in the patient global impression of change. So there were some positive effects that drive and trigger then the start of the phase 3 trial that is present now. There is a lot of discussion also about these results, so just to mention all the different currents, some people wondered whether the positive effect could have been related to potential anti-inflammatory effect of losmapimod, because we couldn't demonstrate exactly a link with DUX4 expression. But obviously, we cannot know this answer, but they did see some benefit. And so now there is a phase 3 trial that is ongoing in US, in Europe, in UK. And as you can see, the primary outcome measure indeed is reachable workspace. So it's not the MMT score like in 2000. And obviously there are other outcome measures in terms of quality of life, and muscle MRI. And the trial is ongoing. It's already 1 year. They're moving towards the open label phase. So to conclude on the small molecules, I guess there are pros and cons of the small molecules. The pros is that they're cheaper, they're quicker to get to the market, they have in general, safety profile. The safety profile is good, and there are a lot of clinical data available. Probably the cons are that might be expensive as well in the long term because it's lifelong administration. If you take an FSHD person diagnosed at 18 years of age, you need to treat them for 60, 70, 80 years. There is something that is a novel, like for many medications. So we don't know if, obviously during the trial, the phase 2 was well tolerated, but we don't know if we treat someone for 20 years if they would develop some side effects, because it's a very broad pathway. It's not a specific DUX4 treatment. And on the other side, like for many medications, you don't know if after 10 years of treatment, there are some compensatory mechanisms that reduce the efficacy of the treatment. So the other big group is about the biologics to block DUX4. There are mainly two categories in FSHD. One is about the RNA therapeutics, so oligonucleotides such as ASO or RNA interference approaches that are going to block and the RNA transcript of DUX4 and reduce the expressions of DUX4. And the other one is about CRISPR that does an epigenetic silencing, reducing DUX4 production as well. As you can see, this field has really exploded. There are many companies, many molecules. They use all a slightly different approach, but the idea is to block specifically DUX4. As you can see, some of them, they use RNA interference combined with an antibody to deliver the RNA to the muscle. Others use nanoparticle. Others combine the antibodies with ASO. And there are two of them that are planning to do CRISPR. So it's a very big landscape, a big field, and there are ongoing clinical trials. So just mention the two trials that are currently available. One is the trial is called Fortitude. So in this case, is an antibody that targets the transferrin receptor to deliver the RNA to the muscles. The trial is currently ongoing in US and UK, and obviously it's a phase 1/2, so the point is about safety and tolerability. So these drugs are given EV and more or less every 3 months. I think you can see in the picture, there are the infusion points. They're going to do also the biopsy at the beginning and repeated biopsy to check as well for the DUX4 related genes, plus all the key exploratory clinical endpoints, including the reachable workspace. The other trial that uses a similar approach is a trial that is started the plan is to start in New Zealand. So in this case, the platform is different. It's a nanoparticle that is able then to deliver the RNA in the muscle as well, and to do a similar approach to suppress DUX4 expression. So the first stage is a single ascending dose, and then they're planning, if it's safe, to move to the part 2, involving other countries. And also in this case, an EV administration every 90 days, 3 months. So it's kind of similar in terms of timing of the administration. And to conclude on this topic, there is the other approach that I mentioned. This is another trial that is about to start, so I think it's worth mentioning because it gives a different view about the approaches that we can use to treat FSHD. So in this case, they use a deactivated Cas protein, so there is no cut of the DNA, so it's a kind of safer profile in that sense. And they bind the DUX4 region. There is a specific platform that is called GEMS that is able to modulate the expression. If you think about that in FSHD, you have an hypomethylation. So if you methylate it again, then you reduce the expression of DUX4, and that helps in curing the disease. In this case, the vector is completely different. It is an AAV vector. You do one-time intravenous infusion. So it's a very interesting approach. Obviously, in these days, I've seen a lot of interesting talk about AAV vector as well, and also the potential side effects of them, and complications like liver involvement, myocarditis. So I think we always have to be careful also considering FSHD and the life expectancy that is not reduced in FSHD. So in terms of the oligonucleotide therapeutics, in terms of pros and cons, the pros is that it's a much more tailored approach. So we're going to target DAX4 and suppress DAX4, so we don't attack a broad, wide pathway. Treatment can be stopped for the oligonucleotide, not for the CRISPR. So if you do have a problem or side effects, you can just stop the treatment. And the cons, like for many of these medications, is mainly to assess the safety, to see if people can tolerate this medication. And because they use for the RNA interference some endogenous pathway, also to see what happens if you continue treating the patient with this mechanism, if they develop eventually side effects. And the lifelong administration, that obviously is still a problem. If you diagnose someone at 16, what do? You treat them for 70, 80 years. So these are the two main approaches, but I think it's worth mentioning also another trial that is ongoing that uses a completely different approach. So it's about myostatin. So as I mentioned at the beginning, you can do you can try to help FSHD attacking downstream. So there are also other studies. There was a study on testosterone. There was a study on creatinine in pediatric population. There are studies on antioxidant to try to target all these components downstream. They show some potential benefit. I think overall, actually, they are useful because we have a lot of patients now. These treatments that are been developing, they're amazing, but they require a lot of years. There will be people affected. So actually having some medication that you can give to the patient now, it would be extremely useful. And the other trial instead is about myostatin. I believe in this audience that myostatin is well known. Just briefly, is expressed in skeletal muscle, is an endogenous inhibitor of muscle growth. So in theory, if you block myostatin, you increase muscle mass. It's not a new approach for FSHD. There have been 2 studies on myostatin inhibitor. The first one was in 2008 using an antibodies that inhibits myostatin. It was part of a bigger study of muscular dystrophies, but included 42 patients with FSHD. And they didn't see much improvement in muscle strength or in functional measures. The idea was that probably the trial was underpowered. They discussed a lot after that. And also they found out that probably there was not a good target coverage. That could have explained why it didn't work. And there was another more recent one that was a local injection done in the biceps brachii and in the tibialis anterior muscles. And also here, what they show that is actually the medication increases the muscle mass, but there were no differences in terms of functional measure, so they stopped the program. So despite the 2 initial trials didn't work very well, there is now another trial using a different antibody that looks more strong, potent to cause the blocking of the myostatin signaling. This antibody, they call it recycling and sweeping. So maybe the antibody is released back to the plasma, and so you can really exponentially potentiate the action of the antibody. So in theory, you require a lower dose, can be given subcutaneously, and the effect of myostatin inhibition should be stronger. So based on that, there is the last trial, I will say, in FSHD, but as we could see, there were many trials in FSHD, so there's another phase 2 trial ongoing now, and as well in US, in UK, and in Europe, where they give the GYM329 compound, subcutaneous injection every 4 weeks, And given the mechanism of the myostatin here, we're really looking at increasing muscle mass. So the primary endpoint is the MRI, plus obviously all the safety and the exploratory endpoints. As usual, the reachable workspace that has been a constant for all the clinical trials, the FSHD-COM, that is a very good scale validated by the FSHD Clinical Trial Research Network to assess function in people with FSHD, and the dynamometer. So in conclusion, I think, we have seen the different approaches that you can see on the right side. To treat FSHD, the current approaches are either doing an epigenetic silencing with CRISPR. You can modulate, reduce gene expression, probably using small molecules, including beta agonists, losmapimod, the RNA therapeutics, that there are several potential trials coming on in the next few years. And also you can act downstream. And from what you've seen, obviously DAX4 is the main target of the current trial strategy. There is the option of drug repurposing that I think is useful because it can bring us nearer to a potential treatment to give patients some benefit while we wait for a more potent approach to knock DAX4 down. But for the biologics, obviously the safety is the main things that we need to establish now. And also add that the last point that I always reiterate in all this meeting when I speak about clinical trials, that all these molecule and treatment are amazing, but we have to remember for blocking DAX4, so blocking the disease, stopping the progression. But there are a lot of people that have muscle weakness. There will be a lot of people that will be diagnosed later on when they already have a lot of weakness. So we always have to keep our mind open as a clinician and try also to find the best way to treat pain, fatigue, disability, mood, and recurrent falls that are affecting the quality of life of people with FSHD. And I would like just to thank the FSHD Clinical Trial Research Network, because I really believe it made it possible to get to this stage of clinical trials, preparing the field with the natural history studies. If you think about the slide of beta agonists, the outcome measure was mainly muscle strength. Now we have different options that we can explore, so we can be more precise in designing clinical trials. And the team at Queen Square that helped the setup of clinical trials in UK. Thank you.
All right, do we have any questions for Enrico? If you have any, feel free to, there's a microphone in the middle. If nobody has questions, what I'd say is our speakers are all going to be here. Feel free to come forward to the front and you can ask them questions. Otherwise, thank you all very much for coming to the Therapeutics